Hi, this is Dr. Nick with the ECG Academy, and this is the last chapter in the basic course, and it completes the section on ventricular tachyarrhythmias. We're going to talk about polymorphic ventricular tachycardia, and we're going to talk about ventricular fibrillation. Now, polymorphic ventricular tachycardia, as its name implies, that the QRS changes. It changes from beat to beat, although there may be periods where the ventricular arrhythmia looks the same. And so it may have a few beats that look the same, and then it changes, and then you may have alternating stuff. So the idea is that it's not the same. So anything that's not monomorphic is considered polymorphic. It's very easy to recognize this, and just like most ventricular tachycardias, you expect to see heart rates between 120 and maybe 250 beats per minute. That can also get up to as high as 300 beats per minute, perhaps. When you get to a polymorphic ventricular tachycardia greater than 300 beats per minute, really that meets the definition for ventricular fibrillation. And the idea is that when you have less than 200 milliseconds in between beats and you have a polymorphic ventricular arrhythmia going on, that's almost always multiple short circuits in the ventricle all going at once. One of the things that you see with ventricular fibrillation is that in some leads you start to lose the QRS complex altogether, and it becomes almost just like a jiggly line with very little discrete QRS activity going on. But we'll see examples of this later in this chapter. Let me first show you polymorphic ventricular tachycardia. This is kind of a bizarre strip, and it's pretty brief, but it proves the point that you have a sinus beat in the beginning with a P wave and a QRS complex that looks fairly narrow. And then you have these wide, bizarre beats. There may be retrograde P waves in between them, but it's almost like no two beats look alike. You've got three going down, and this one's up, and this is almost biphasic, and then you have another run of crazy stuff. It's very, very irregular, at times even as slow as 100 beats per minute. And the interesting thing is that when you look at one of these beats and you examine the QT interval, it's only about 360 milliseconds. Now, this is very important. When you see a polymorphic ventricular tachycardia with a fairly normal QT interval, really that's what you need to call it, polymorphic ventricular tachycardia. And in fact, clinically speaking, this really is ischemia until proven otherwise. So you really have to start thinking about ischemia in these patients because polymorphic ventricular tachycardia really is like a sign of myocardial instability. But this is not torsade de pointe. Torsade is a completely different animal. Let's go back to our model here, and we'll talk about this very specific arrhythmia that comes from the French words meaning to revolve around a point or to turn around a point. And the initial idea behind this arrhythmia was that somewhere in the ventricle there was a reentry circuit that was going around, but that circuit was actually spinning in space very gradually, sort of like turning around on its axis and then kind of going upside down and around. And what you see is a polymorphic ventricular tachycardia that in the books kind of looks like it's get bigger and smaller and then bigger and then smaller again. And it's a very characteristic appearance in the textbooks, where it says bigger and then smaller and then bigger than smaller. And everybody can recognize this. Oh, yes, of course, that's torsade de pointe. But it's not always torsade de pointe. Not every ventricular tachycardia that gets bigger and smaller is torsade. There are very specific requirements that you should look for before you diagnose torsade de pointe. And these are the ones I look for. First, you're looking for rates of 200 to 300 beats per minute. And so if you see rates in the range of 350 with less than 200 milliseconds in between beats, really you're looking at ventricular fibrillation. The second thing is you absolutely should see a long QT interval. Now, there are rare exceptions to that rule, but in almost all cases of torsade de pointe, the QT interval is long either because of drug-induced long QT syndrome, otherwise known as Dillquits, or congenital long QT syndrome, LQTS, and there's a whole bunch of those that we'll talk about in the advanced course, or some kind of electrolyte abnormality that results in a long QT interval. But this is very, very important. The long QT interval is a must, and I'll show you why. If you recall, At slow rates or long intervals, the QT interval generally is longer than it is when the heart rate is faster. And that's normal. When we talked about intervals, we talked about how you correct for the heart rate to get the corrected QT interval. And the way I've drawn it is that slow rates will result in longer QT intervals, and faster rates will result in shorter QT intervals. But as I mentioned, this changes from one beat to the next. And that's why you'll sometimes get functional bundle branch blocks because of prolongation in the QT interval. Well, what happens with torsade is there's such a bizarre abnormality in repolarization that it results in ventricular arrhythmias, but it's especially worse after a pause. And so what you'll generally see is pause dependence, and I'll show you what that looks like. It means that there's usually a long interval before the normal beat that precedes the ventricular tachycardia. So it's pause dependent, and I'll show you examples of that. Lastly, the first beat of the tachycardia arises from the T wave. Because the QT interval is long, then that means the first beat of the tachycardia is late coupled, meaning that the rate is relatively slow when it first starts off. Let me just show you an example of torsade. Now here it is, it's a polymorphic ventricular tachycardia. Wide and bizarre, really big negative QRS complexes in the beginning, and then they get much smaller, and then actually becomes positive towards the end here. And then down here there's another run, but this doesn't look exactly polymorphic though, does it? It does a little bit here, but I want you guys to get away from the idea that it's always going to look like this, because it doesn't. What's more important is when you look at this normal beat with a P and a QRS, look at the T wave. Where the heck is it? It's over here. Look at how long that QT interval is. If you measure from here, it's 2, 4, 6, almost 700 milliseconds. It could even be 800 milliseconds. It's enormous. And that first beat of this polymorphic ventricular tachycardia arises from the tail end of the T wave. Look how slow it's coupled. It's coupled at a rate of about 68 or 70 beats per minute. And then you get sort of this takeoff. There's a little bit of a warm-up in the tachycardia before it kind of finally peters out, and then you have a normal beat again. Torsade de pointe can be non-sustained, or it can become sustained and can even degenerate into ventricular fibrillation. Now, when I said pause-dependent, I was referring to the pause that precedes the normal beat that kicks off the arrhythmia. So look at this interval right here. From the last beat, there's a long pause. This long pause right here causes this QT interval to become even longer than it was before. And then with this bizarre T wave, you get the first beat of tachycardia, you get a run of torsade here, and then it finally stops. And then with a normal beat takes over, you have another run, and then there's a little bit of a pause here, and that causes this QT interval to become very long, and you have another run. So you actually get this kind of bigeminal pattern where you get a run and then a pause, and then a beat and then a run and then a pause. So you get normal beats kind of sandwiched in between runs of polymorphic VT. This is very characteristic of torsade, but as you can see, it doesn't have that bigger, smaller appearance to it like you have seen in textbooks before. Let me show you another example that's even less characteristic. Here's an example of classic torsade in someone who got the wrong medication, and it wound up causing their QT interval to be very long. Now, if you look at the QT of this first beat, it's about 500 milliseconds. It's very long, and there's a PVC that arises from the tail end of the T wave. Well, that PVC results in a compensatory pause. And with this compensatory pause, you have a normal sinus beat, and the next T wave actually has like a U wave on top of it. So the TU complex becomes very long, and you have another PVC. As I said, that's like often a bigeminal pattern. Then with this compensatory pause, you actually have a junctional beat here. The P wave and the QRS complexes are occurring simultaneously. And with that beat, your T wave, look how big it is compared with this one. This is kind of a small T, then it got a little bit bigger. Now you've got this huge looking, very bizarre T wave, and the first beat of tachycardia rises from the T wave relatively slow, here at a coupling interval of maybe 100 beats per minute, but you get this polymorphic VTAC. but it doesn't look like it gets bigger and smaller. But clearly the QRSs are going down in the beginning, and then it sort of becomes sort of biphasic here, slowing down slightly, and then these QRSs are clearly going up. And so the axis of the QRS complex is changing, and that's what makes it polymorphic. And it's the long QT and the pause dependence that makes this torsade. It's the same thing down here. Actually, this is the same strip, just a little bit later, because now you can see another pause after the VT breaks, and then you see another short run of clearly polymorphic VTAC in this sort of bigeminal pattern. Make sure you look for all the ingredients of torsade before you call it that, because if it's not torsade, then it's just plain old polymorphic ventricular tachycardia. The last arrhythmia I want to show you in this section is this, and I think this strikes fear in the hearts of men and women on the telemetry unit. It's ventricular fibrillation. It's ventricular fibrillation because it's polymorphic and it's at a very rapid rate. You can see over here, clearly rates faster than 300 beats per minute. And here, it's almost like the QRS complexes seem to disappear. Where's the QRS? It's almost just like noise here. So that's pretty characteristic of ventricular fibrillation as well. So it's polymorphic, is generally greater than 300 beats per minute. And this is something that's nearly always fatal, but on occasion it will stop on its own. So don't let people fool you into thinking that once you're in ventricular fibrillation, there's no hope. And with that, I hope that I've shown you how to recognize almost all of the more common arrhythmias that we see on rhythm strips. And that was really the purpose of this basic level, is to deal with arrhythmias that you'll see on a rhythm strip and to introduce a lot of subjects that you need to be familiar with if you're going to read 12-lead ECGs. The intermediate level of this course will cover all the nuances of reading 12-lead ECGs, including subjects like hypertrophy, atrial abnormalities, and STT wave abnormalities, so you can look for things like ischemia and acute infarctions. What the advanced course gives you is additional insight into the more complex arrhythmias like PSVT and how to recognize the presence of a concealed accessory pathway versus AV nodal reentry tachycardia, and other complex subjects like recognizing which side of the heart an atrial flutter is coming from, and even how to localize where ventricular tachycardias are arising from. The advanced course is going to be filled with great stuff. So if you're interested in becoming an ECG expert, then that's the level that you should shoot for. In the meanwhile, I'm glad you subscribed to this basic level, and I hope I was able to present this information in an interesting and understandable way. Well, this is Dr. Nick Tulo. Thank you very much for subscribing and supporting the ECG Academy. With your subscriptions, I hope to bring you more and more information and help you master the electrocardiogram. Thank you all for your support.